Hi, everybody. This is Susan Clinton, one of your co hosts for Tough to Treat. We're excited to be here. It's episode number 183. And this particular podcast is a recording of part of a course that I teach. And this particular piece is colorectal sensory motor integration. It'll give you some really good information about treating people with GI dysfunction or recognizing it, especially if they're hypersensitive versus hyposensitive. I hope you enjoy the podcast. Also, I just wanted to point out a few things going on this fall. You can catch me in 4 places. On October 28th, I'll be presenting with APTA and Select NovaCare, who are sponsoring a live and online conference on access to pelvic health. I'm going to be talking about the intersection between chronic low back pain, urinary incontinence, and GI dysfunction. On November 3rd, you can catch me speaking at the Pelvic Health Solutions Symposium in Canada. It's going to be a wonderful conference full of lots of different practitioners for the day. And on November 8th and 9th, you can also join me with Pelvic Health Solutions for a course on missing pieces, challenging treatment and intervention of GI dysfunction. Finally, I'm going to be in New York City on November 12th and 13th for a course with Andrews University, and this is going to be GI dysfunction and the orthopedic client. We'll have all the links up on the website, and we'll also have the links for registering in the emails that come out. Thank you very much. Enjoy the podcast. This section is going to discuss the colorectal sensory motor integration effects of the GI system. So we've talked all about the different things that can happen with the GI system, and we've talked about some physical therapy interventions, but I want to pull it all together in a sensory motor integration pattern for you so that you can kind of find where your patients might fall into a typical algorithm that would work for them. So one of the things we want to consider when we're looking at sensory integration is there too much sensation in the GI system, or is there not enough sensation in the GI system? And for this particular talk, we're going to be just focusing on the rectal and anal piece of this, and we'll get to the abdomen in a few minutes. So the first thing we're going to talk about is not enough sensation. So when we're just thinking about the rectum, we want to think about what are the situations that would give the rectum not enough sensation. The first one that comes to mind is one thing we talked about, which is the loss of the signal. In other words, for some people, especially your chronic constipators, they can have stool drop into the rectum. The rectum only gives pressure readings when the rectal walls are stretched, and the brain responds to that. If we have extinguished the signal because we've been chronically holding all our life, or we have been in a job situation where we weren't able to go to the bathroom as we needed to, oftentimes we'll extinguish that signal. And it doesn't mean that the rectal capacity is lost, it just no longer listens to the signal at all. And so one of the things we want to be able to do is bump up the signal, and one of the best ways to do that is with the balloon catheter. So you can take the balloon catheter, insert it into the rectum above the anal canal, and work on trying to find the signals that they feel with pressure. So you want to go for that first urge signal, that mild one, like, oh, I think I need to go to the bathroom. And then you want to pump up the balloon until you get to a pretty good loud urge signal. And if it's pretty high up there, 120, 160, 200, you can work on beginning to increase or raise the sensory level by bringing it down, getting them to be aware of it, bringing the balloon back up, letting them feel that, and really actually have them understand the target of what that urge is again for them, because they've lost that. If they are at that high rate or a big balloon before they actually get an urge signal, one of the other things you can do too with the balloon is you can actually take the balloon, insert it into the rectum, away from the anus, and you can bring the balloon up to about 60 or 80. And one of the things that I like to do with that is actually have them explore what else is happening in their body. Oftentimes, when you get enough of a bolus to stretch the rectum and the capacity is normal, then what they'll begin to tell you are other things such as, my abdomen is starting to cramp, I feel pressure in my tummy, I feel like I'm bloating a little bit, or I've even had some people say, I feel heartburn. So remember that the GI system is sensitive to pressure all the way through. If they've extinguished the signal to go to the bathroom at the rectum, oftentimes the brain may be amping up the signal somewhere else. So this is a great time for them to understand that, oh, there's a bolus of stool in my rectum, but I don't feel a normal urge to go, but I do have abdominal cramping. Maybe that's where my call to go to the bathroom is. So you can look at it that way. The second thing that can happen in the rectum is an increased capacity. And when you have an increased capacity, that means that you've got a baggy rectum. These are going to be for people who have been storing stool for a very, very long time down in the rectum, and now it is stretched out. This is not going to be something that you're going to be real successful with the balloon catheter, because it's not going to ever really get big enough to stretch the walls of the rectum. So they're going to have to look for other cues. This is where you may need to drop down and start getting them to feel a little bit more down at the anus so that they actually know that stool is down there and can be going on with them. You can still try the balloon. Maybe you can try it further up in the rectum to see if you can get an urge signal, or maybe even if you just begin to blow it up and put some pressure in there, they may feel it higher up in the system and not down into the rectum. So you're not going to really be able to do a lot of training for sensory stuff if the rectum is really baggy. Once you kind of lose that fascial, connective tissue component, it doesn't really return. So this is a little bit of a tougher issue to deal with. You can get bigger balloons and work on those. If you want information on that, you'd have to email me offline, and I can direct you to the right people that can talk to you about that, but it's not something that I typically do in my practice. So this is the loss of signal at the rectum. What happens when we lose the signal at the anus? Well, we can have problems that can occur with, if you think about it, neuropathy. So let's think about all of the different ways a neuropathy can occur. It can occur with chronic stretching of the pudendal nerve. It can occur through childbirth, vaginal delivery. It can occur through trauma and injury. Or it can occur through metabolic diseases such as diabetes. So when you have a neuropathy, you're going to have a decreased sensation at the anus. And oftentimes what that's going to lead to is what we like to call the anal incontinence, right? It could be called fecal incontinence too, but generally people with neuropathies are going to be losing much bigger stools. They're not going to be losing the stool that is a seeping, liquidy, diarrheal type of stool. It's going to be a much bigger stool. We can actually help people with this, but this is going to be through more of the motor integration of what you want people to be able to do. So this is where you can teach people to use what muscles they have and bulk them up as best as they can while they're waiting for the nerve to remyelinate. So we have to think about this a little bit. If they have a stretch injury strong enough to interrupt and start the change process in the nerve, then it demyelinates all the way up proximally and has to remyelinate all the way around, all the way down distally. So there could be some sparing left. You want to bump up the force production of that muscle while the rest of the nerve remyelinates down. This is the time where you also teach people about grabbing that gastrocolic reflex. Eat enough to stretch your stomach and go sit, and do that every day at the same time every day so that you can begin to set up a bowel program for them that they can rely on. Also, you can use the balloon here to let them pay attention to and bump up the volume at the rectum so that they're aware when stool is getting into the rectum, because they're not going to feel it as well here at the anus when it drops down. So when they feel that here at the rectum, they know that I'm going to need to go to the bathroom because I'm not going to have the motor control to stop the stool from coming out once it drops down to the anal canal. The final thing that you can do with the balloon catheter here in a situation where they may have poor muscle force production, whether it's due to a neuropathy or not, or just we can just run in here with this, weak muscles. Maybe the muscles got torn, maybe the muscles got injured. I say childbirth a lot because that's usually the big event for a lot of people. But there are a lot of people who may, with straining or something, have strained and made their muscles weak because they got overstretched and they just weren't using them as well. Or sometimes when we get into atrophic situations, the muscles are weak. This is a really neat idea. I mean, we're doing progressive resistive exercises with just about every other part of the body. It's kind of cool to be able to do this with the balloon, because what you can do is blow the balloon up just enough to feel like a good bolus, somewhere, I don't know, 20 to 40 milliliters, and just bring it down to where it engages the anal canal from the inside. And there you can actually have people stand up and work on tightening up and lifting that balloon back in. So you can pull the balloon down like it's going to creep out and have them work on lifting and pulling it up and back in. This is a great way to have them actually functionally work on those muscles against a bolus of stool. So that can be very, very helpful for you. The last thing I'm talking about, not enough sensation, is going to be the idea of paradoxical diarrhea. And we definitely discussed that in the lecture material that I put online. So here's what we're going to talk about with that. So we're going to think about paradoxical diarrhea, realizing that this is a hallmark sign of constipation, especially constipation further up the chain. So we've got the sludge coming out and things that are happening here. And one of the things that can happen here down at the anus with this is you've got this fecal seepage. And oftentimes people will come to you saying to you that they don't have constipation, they have loose or watery stools. When you trace back to their Bristol stool, you'll find that most of the time they have a kind of a normal bowel movement first. There's a break off of some of the impaction, and then that's followed by fecal seepage, and it keeps going that way. And they're unable to stop it, and they have a lot of wiping and skid marks in their underwear and things like that. So what we want to think about is, what can we do with that? Well, you can do some motor integration and pump up the volume of the force production if it truly is a force production problem. But it's really, really, really hard to stop the sludgy river from coming through the back passage. So I would almost say that you can get them a little bit better with motor control, but you're not going to get them all the way that they need to be. These people really need to go back and work on diet and get cleaned out, have a flat plate x-ray, make sure they're not constipated up high. If they are, get cleaned out, start over with a good diet, maybe an elimination diet, and get rid of the inflammatory food so that they can begin to settle this down. Then you can start to work on, do they have a loss of signal? And have they just not been listening to signal? Because remember, if they're chronic constipators and they're kind of getting into this paradoxical constipation, this may be part of what's going on. But this is not the first thing you treat with that. You got to take care of this part first, maybe some motor work, and you got to take care of the constipation first. Then you can get over here and start bumping up the signal of the rectum and finding out what signals they need to listen to in their body if they're not getting a good pressure sense reading from their rectum. So when we consider now, after looking at not enough sensation and all of the things that can go wrong there and what you can work on, we can also flip the coin and think about our patient who has too much sensation. This is your hypersensitive, maybe central sensitized chronic pain patient, as well as people who may have local tissue sensory issues as well, like just a lot of pain down at their back passage, a lot of pain maybe in their muscles or tender points in their muscles. This can also include the abdominal sensitization as well. Again, we'll get to that in just a few minutes. We're going to stick with the rectum and the anus on this point. So one of the things we can have with people with IBS is you can have the constipative IBS, right? And you can have the diarrheal. And most of the time, your patients are going to be mixed. So they're going to flip from one to the other. And remember, with IBS, the hallmark sign of that is abdominal sensitization. A sensitive abdomen generally feels worse before bowel movements, generally feels better or relief afterwards, generally feels worse after they eat. So keep that in mind as we kind of go through. So what are we thinking here? We're thinking that this system is very, very sensitive, and if they have increased sensitization in their abdomen before a bowel movement, we might start thinking that there is, the rectum, the sensory part of the rectum is dialed up. And that pressure, whenever they feel any pressure in their rectum at all, it may be something that the brain is taking on as, oh, this is an emergency, rather than maybe just the quiet pressure that it's actually sending upstairs. So the brain is magnifying the signals from the rectum. One of the things you can do with the balloon catheter, which is really great, is you can actually insert that in above the anal canal again so that you're just on the rectal wall. And you can work on just finding out where their baseline is. How much, when I begin to put air in the balloon, how does that feel to them? Oftentimes when people have too much sensation, they're going to start saying that they have a very, very, very strong urge to go at numbers much lower than 60 milliliters. So they're going to be your ones that are going to freak out just a little bit when you do the balloon catheter. So, but this is a great tool because now you can say, okay, I got it, and deflate the balloon. Then you can gently raise the balloon and have them breathe through it and understand that, it's just a bolus of air in there. And this is perfect because they'll talk to you all the time about the pain they get and the symptoms that they get, but this is the best way for you to actually bring it on in a way that you can work with them while they actually have it, so that they can understand that sometimes it may not be enough pressure or enough stool to have a bowel movement, so I need to calm that down and wait until I can get a bigger urge. Right? Because these are the people who actually end up going into the bathroom and straining because they're so sure that they have to have a bowel movement, and maybe their stool just isn't big enough into the rectum yet for them to have one. So you can just deflate the balloon, increase it slightly, deflate it, increase it slightly, work with them on their symptoms as they come on. Find out where else their symptoms are in their system. They may have that concomitant abdominal pressure or pain as well. Have them do the things that you've already worked on in physical therapy to make that better. They could do the massage right then and right there. They could do some of their breathing. They could do their autonomic quieting. They could actually even get up and move around because you've got the catheter inside. Doesn't mean they have to be laying on the table. They can get up, they can move around and do the things that they are, that they have chosen to do to try to help their symptoms when they come on. So we have to think about that in terms of, if they're constipative and they're IBS, it may be that they're holding stool because they're afraid to go because of pain. So all of these techniques may work, but you may still find even on the constipative IBS patients that they have a real reaction to the sensory component really much sooner than the people who don't have enough sensation. Okay, so that's kind of the difference there. Oftentimes with too much sensation, you can also have a capacity change. So this may be people with a decreased rectal capacity. And so here you want to think about maybe people who have had surgery and they've tightened everything up. Or you can also think about your post-radiation patients and how that might affect the rectal capacity, because it's certainly going to make it much smaller because of the scarring from the radiation. So the balloon can work to help you begin to increase that capacity a little bit by doing some gentle stretching into the rectal walls, which is really nice. And it also can help you if they're having too much sensation or hypersensitivity around that. It can also help you be able to dampen that while you get some stretching done into that rectal wall, which could be of great help to them. What you may find with surgical radiation is that we get a loss of signal. So they may become more hyposensitive, we just don't know. So, but I put it here because it goes with the decreased capacity, which is going to make them not able to form a good stool. If they do form a good stool, it may hurt. So, so you kind of get into that too much sensory piece over here. But one of the things that may occur with radiation is a loss of signal, so that you can work on that as well. You'll just have to see how it comes when you begin to peel that onion back and figure out the pieces that you want to work on. As we move down to the anus and we consider the things that might be driving up too much sensation for the anus, we want to start thinking about things like increased pelvic floor muscle overactivity, or guarding, right? Guarding and protecting goes along with too much sensation, pain, persistent pains, kinds of things. So we can certainly have that, which would be with, a lot of tender points and, decreased mobility around the area. We also want to think about other things that cause pain that may drive our patients to start actually moving into kind of more holding patterns here or here. And that could be things like hemorrhoids, right? Active hemorrhoids, especially internal and external, fissures, and scar tissue that could be painful. That could affect and cause us to say, ooh, too much sensation, too much pain. I'm really uncomfortable there. One of the things that I see a lot in my clinic is sometimes I'll get the people who need first aid right away, and that's generally in my postpartum population, and sometimes in my menopausal population. However, a lot of this stuff heals, right? And the hypersensitivity doesn't always have to change even though this heals. So you may be faced with I need to do some stuff to get that scar much more mobile in the back passage so that the tissues can lengthen and change and do the things that they need to do for a bowel movement to come out. But they have some hypersensitivity here. Same thing, hemorrhoids may have healed, but left them with a hypersensitivity in the local area. And maybe it's turned into a little bit more of a persistent problem upstairs. So they have some allodynia around areas where they actually did have tissue problems. This is a great way to use the balloon catheter to kind of treat, because what you can do is bring that balloon catheter down to where they feel this hypersensitivity right at the anal canal, and you can work on their sensitization there. So instead of being up higher into the rectum, this is the time where we're going to be down into that anal canal, and you can actually bring the balloon, you can make it smaller, bring it down in, and have them begin to do the things that they need to do. Maybe they're going to drop into a deep squat. Maybe they're going to do some breathing, maybe a couple of reverse pelvic floor muscle activities, things like that to begin to elongate those muscles and help those muscles either change or not be guarding so much. Same thing, you'll be doing the same thing. You can use that to help stretch some scar tissue and things like that in the area as well. If you wanted to do your other physical therapy modalities, those all work here. Biofeedback to calm things down, and definitely any kind of external techniques that you have are going to help bring circulation to heal fissures, work with scar tissue, and just get the whole back passage much more mobile in the system. Finally, I just want to tie this all together when we think about our patients that have been diagnosed with dyssynergia. Because I think rather than just diving in and treating the motor control issue of dyssynergia, I think it's important for us to take a step back and go, why is it there? Why is dyssynergia there? And one of the things that I always want to know is it because of pain or is it because of chronic holding, right? Those are really the two types of people that we see all the time. And you can see that the pain category falls into too much sensation, and then chronic holding falls into here. But one of the things that I think is really super important to understand is you can get a mixture across the board here. So now what we can have is we can have pain that causes us to have a loss of signal because we're afraid to poop and it hurts. So we begin to hold and say, I'm not going to the bathroom. I don't care if you think I have to, I'm not going. And make that occur that way. We can also have this happen up here with loss of signal and the chronic straining, that leads to the neuropathy, and the chronic straining can lead us into these kinds of things: hemorrhoids, fissures, tissue breakdown, and pelvic floor muscle guarding and overactivity. So dyssynergia is going to actually, because people always ask me all the time, well, dyssynergia, what do I work on? And it's like, take a step backwards and try to figure out what the biggest thing is, the biggest problem that you have that's really driving the dyssynergia. And that's the piece that you work on. 9 times out of 10, I will tell you that I got to get after the pain piece first and make sure that the hypersensitivities and some of those things can calm down before I can get into the loss of signal and the motor control and integration. Because if we've got this persistent pain thing going on over here, it's always going to be harder to get the motor control piece back, because the inhibition and overexcitation of certain muscles underneath persistent pain syndromes are going to still be pretty dominant patterns. So I like to go after the dominant patterns first, and then begin to tackle what becomes, the stuff that's left over there.